Welcome to Med-Surg. This is the orientation that every new nurse deserves, but almost no one gets. So if you're a new nurse and no one has explained this to you, this is the series for you. I'm Nurse Key, and I've been a nurse for 6 years. I'm currently a registered nurse. I started off as an LPN, and I'm working my way through NP school. So today we're going to talk about how to structure your Med-Surg shifts so it's like you're not playing catch-up all day. So let's get into it. So most new nurses think that their shift feels chaotic because they disorganized. Now there may be some truth to that, but it's usually not the problem. The problem is that no one ever explains how the shift is actually supposed to flow. So instead of working in phases, you keep reacting. Instead of being proactive, you are reacting to everything that comes up in your day. So, Med-Surg shifts work best when you actually think in phases and not individual tasks. You're not just passing medications, you're not just charting, you're not just doing your assessment. You are moving through stages of the shift. When you understand the flow, you stop feeling behind all the time. So I like to think of clustering my tasks through the day, but it starts with the overview of how my shift is supposed to work. So let's get into it. So you know that when you first come into the shift, it's going to start with handoff and you do your bedside assessment, right? Handoff should be done at the bedside and you're going to look for 3 major factors. Breathing, is this person breathing? Equal, rising and falling of the chest. Unlabored breathing, no shortness of breath, no signs of distress. Bleeding, is this person bleeding or any types of discharge that needs to be attended to? Bowels, is this person soiled of urine or stool? Pull back those covers, look at the bed sheets, make sure everything's clean, dry, and intact as it should be. No distress, no stains, and no necessary needs right now at the moment. If everything is good, your medicines are not dry, and everything is standard as how it should be, go ahead and review your chart. Go to the computer, pull up each patient, see what the plan is for the day, what meds are pending, what labs need to be done, do they have physical and occupational therapy orders, what are the orders for your patient. You'll start to write this on your report sheet so you can actually plan your day. I like to do time blocks of like 2-hour increments. So let's say I have a day shift, I'm going to do 8, 10, 12, 2, 4, 6, 8 on my paper. While I'm looking through the computer, I will fill in the gaps of what is ordered so I can plan my day. There are some standard things that you know is going to fall in those categories. So if you get there for day shift, you start at 7. By 8, you already know breakfast is coming. Blood sugars need to be done prior to the meals. So at 8, so really at 7, 11, and 4, blood sugars need to be done. Go ahead and fill those in. Then you have your meals, breakfast, lunch, and dinner. So at 8, 12, and 5, those are meal times. Does that patient have to get out of bed? All right, for meals. So, and then you'll have your medications, which I like to do around around the meal times. That's going to be with 8, 12, and 5. The medication administration is going to happen as well. And then you'll fill in the gaps if it's any other medications that doesn't fit in that timeline. Now, you have your hourly rounding, or every 2 hours, right? Because you can round on 1 hour and then your CNA or tech can round on the opposite hour. So when you round, you're going to look for toileting, positioning, and pain. Go ahead and fill those out on your report as well. So, like I said, these are phases of the shift. You don't go into a shift blindsided and then just take whatever the day has thrown at you. No, you have a system, you have a structure. Once you have designed your structure, now you articulate that to your patient and everybody else working on your care team. And it also provides that when you have a structure, if there are any outside interruptions that come up, you're not so thrown off as to, oh, well, what else do I have to do? You already have your plan in place. So any interruptions come, you can handle them and go right back on track as to what your plan was for that shift. All right, so we're going to say the start of the shift, right? We know about the handoff. At the beginning, your priority is going to be assessment and safety. That means quick safety checks, right? The 3 B's, breathing, bleeding, and bowels. Head-to-toe assessments are going to happen after your chart review and you go back in. You're going to tell your patient, hey, this is our plan. You will introduce yourself. This is our plan for today. I'm going to look at your skin, do a quick head-to-toe assessment. You're going to look at their IVs. Are they patent? Do they run? Is it dressed, dry, clean, and intact? Is it date and timed on the label? Does the dressing have to be changed? What about the oxygen? Are they on adequate amount of oxygen? Is it documented into the chart? What about their drains? Are their drains less than 1/3 full? Does that site look clean, dry, and intact? You're also going to identify who looks stable and who doesn't. This is not the time to deep dive into charting or perfect notes, but you need to build a mental picture of your patients. The next phase, like we said, you have to get prepared for medications and interventions. Once you know who's stable, you're going to move into these things. This is where you administer your scheduled meds, you address your pain, and you start executing the plan of care. Now, with some medications, you cannot do this without having certain information, right? Not only are they stable, what are their vital signs? What is their blood sugar level? What is their pain level? So the first phase is like getting your baseline. You have to get to your vitals. Are they stable? What does their skin look like? You gather the details, you review the chart, you look for the orders, because in phase 2, that has to build onto what you now have to do as your interventions. So this is the key. You prioritize your medications based on the patient's acuity and not just the room number. Now, phase 3, you're going to reassess and adjust. So after your medications and interventions, you reassess. You look for the responses of your interventions, right? Did the pain improve? Did the oxygen requirement change? How is the blood pressure responding to the medication that I just gave? So assessment does not stop once you chart it or once you intervene. It is a constant scan of how that patient is responding to your interventions and just throughout the day. Now, phase 4, you're going to document and you're going to anticipate. This is where documentation fits the best. I cannot document every day because patient care actually comes first. I chart after the fact, and if any major status change happens, I will document at the time it occurs. So you don't document all at once, but you also don't document hours later. You document in pockets within the shift. And while you're charting, you're also anticipating the discharges, your labs, procedures, and potential problems that may come up in the shift. So here's why new nurses get stuck. They get stuck when they try to complete everything perfectly in order, like this is a systematic process. So one interruption will throw off your day. But Med-Surg and nursing in general requires flexibility. You have to loop back through the phases multiple times because every patient is different, every day is different, and interruptions will come up. So you plan for success, but you anticipate interruptions. Now that's the key. A good Med-Surg shift is not quiet, rarely. It is controlled. You won't finish everything early. I'm gonna just lay that out here now. And you won't feel caught up all at once. But you will keep your patients safe, and that's the ultimate plan anyways. Now, this is the exact shift breakdown that I have included in the New Nurse Fast Track Guide. It helps you to organize your day, prioritize care, and then cluster your care and adapt when things change without feeling overwhelmed, burned out, or like you're failing. So if you want in on that structure, go ahead and click the link in the bio. It's the New Nurse Fast Track made for new nurses just like you. And I also have the ICU nurse version. So either if you're acute care or you're in critical care, go ahead and get the book today. Link in the bio. Welcome to the Med-Surg orientation that every new nurse deserves, but one rarely gets. My name is Nurse Key. I've been a nurse for the past 6 years. I'm an RN. I started as an LPN, and now I'm working my way through NP school. So if you're a new nurse and no one has ever explained this to you, you want to follow this now. This series is for you. So we're going to talk about what to look for in each body system. Now, you should know how to do a head-to-toe assessment, right? We've all went through health assessment. They drilled that in our head, but some of us are still wondering, what are we even looking at? What are we even looking for? What is the big idea? And that's what we're going to talk about today. So by the time you're on a Med-Surg unit, you should already know how to assess. And it's no tea, no shade if you don't really understand, the basics, but let's go over it. You learn the lung sounds, heart sounds, neural checks, GI, and GU. You know the anatomy. You should know kind of what the normal looks like. So when you assess something abnormal, you should now know what to exactly do next. So this is the rule I want you to remember. You're going to assess to establish the normal, the baseline for this patient. And when you assess abnormal findings that do not match your baseline of this patient, those findings must be reported and documented. So there's two truths. There is a normal anatomy and physiology of the human body. And then there is a patient's normal and baseline anatomy and physiology. You need to know both. Nursing school taught you the normal human physiology. Nursing will teach you your patient's normal and baseline and anything that changes within that. Now, when you get to the bedside, you are going to do your assessment. You are going to say, hey, now, if I know the normal anatomy and physiology is this is where my patient is starting at. Document how you found them. As you go through your shifts, you are going to then document any trends, changes, or anything that stays the same with that patient, right? Assessment without reporting and documentation is incomplete care. So I'm going to walk you through the major body systems and tell you what should stand out in nursing in general, but particularly in Med-Surg. Let's start with the neural system. With neural system, you are comparing it to the baseline. You are watching, well, actually, let's start here. The baseline for a normal anatomy and physiology, right? You want that person to be alert. If this is daytime and they are not sleeping, you want them to be alert. What does that mean? When you walk in the room, they respond by looking at you, speaking to you, or at least acknowledging your presence. They are alert. They don't have to be touched, stimulated with pain to get them to wake up and respond to any type of stimulation. You want them to be of sound mind. What does that mean? They're able to tell you their name, date, where they are, and what month it is or what year. They are in present tense. They are oriented times 4. Anything outside of that could be their baseline, but anything outside of their baseline now is a new symptom. Any new confusion, any level, any change in level of consciousness. If they go from alert to lethargic, that's a problem. If they go from lethargic to unresponsive, that's a problem. If they have consistent, clear speech, right, and then they go to slurred speech. If they go to aphasic, where they're not able to actually articulate the words, or they're articulating, but it does not match what they're actually trying to say. If they say that this is now a bottle versus a phone, or they say this jar is a wheelchair versus a jar, there's a problem. If their pupils are equal, reactive to light, and it's symmetrical, and it is brisk, when you do your pupil reaction assessment, and now it goes to sluggish, or is pinpoint, or is dilated, that is going to be a change. If you have a new weakness, when you do your motor skills assessment, when you do your where they grasp the hands symmetrical, it should be strong, flex their feet. If they now have no strength in their hands, if they're not able to pick up their hands, or it's a drift, or it's no movement at all, that would be a change. If they are at once able to follow commands, they're able to squeeze your hand and release, and now they cannot do anything, that's a change. These are some examples of what you're actually looking for. Now that may be easy to understand. Now let's go to the next one, respiratory. Now, I hear so many new nurses, they say, well, I'm listening to the chest, I don't know what I'm listening for. When you are listening for breath sounds, it literally sounds like someone breathing, right? This is the example. Take a deep breath in and release it. You can literally hear this in someone's chest. That is called a clear breath sound. You didn't hear, I don't have any sputum, like where it's like crackly. I didn't have a diminished breath sounds, or even me just breathing audibly. The difference is, this is clear, right? Diminished would be like I turned down the volume on the breath sounds at the lungs. Crackles is like literally I have water or I have fluid over my lung sound. So even, you know how you might have sputum kind of in your throat, lungs, you hear that. That's kind of what crackle sounds like. Rails is almost like I'm crinkling plastic. It's like a crackling sound. That is rails. Those are the most common that you need to know and document appropriately. Crackles can be cleared. You'll ask that patient, hey, can you cough, like be a productive cough? Can you maybe clear your airway? Sometimes those crackles will decrease depending on if that person has a cough and gag. So those are always good to know. Now, of course, with the respiratory system, you look at the respiratory rate. You look at their respiratory demand. Are they, is it unlabored breathing or is it labored? Right now, I've been breathing this whole time and it doesn't look so obvious. When it becomes obvious that someone is trying to catch their breath, this is what we call labored breathing. I don't have a work of breathing, right? I'm sitting at ease. I'm not posturing, I'm not nasal flaring, I'm not using accessory muscles. That means I'm no shortness of breath, I don't have respiratory distress. Anything outside of that now, right, that would be a problem. This is abnormal. That's something to think about. Sometimes it's like on the textbook it doesn't make sense, but in real life you have to apply it to how you actually see people to make it actually connect. So again, any abnormal respiratory findings are going to be escalated and documented. When you come to assess them, you want to say, this is how I receive them. And now anything outside of that is going to be abnormal. And you want to make sure to compare it to the previous shift to say, is this their normal too? Because sometimes you're walking in a crisis and you don't know what their normal has been. So you have to compare to see, okay, has there been a change? And that's why handoff is so important. Cardiac system. With cardiac assessment, you're focused on stability, right? You assess the heart rate, the rhythm, blood pressure trends, and perfusion. But cardiac, sometimes even with that, we listen to the cardiac sounds, S1, S2. Okay, you hear a heartbeat, great. Cardiac is more than just the heartbeat. It actually is a circulation for the entire body. It's going to affect your temperature. It's going to affect, are you having like fluid overload? You have edema. Edema generally is seen at the ankles and it goes up. If I elevate my patient's feet and what appeared to be edema has now transitioned, now it has resolved, maybe it was just postural, positional. Do I hear fluid over the heart? Do I see that their pulses are bounding, or they're regular, or they're thready? Is their blood pressure low? Is their blood pressure high? Is their heart rate high? Is their heart rate low? Again, know what that patient's baseline is and watch the trends. All abnormal cardiac findings must be reported and documented, especially if you're on a cardiac floor, they already have a cardiac diagnosis. You'll need to know with each diagnosis, what does that actually look like, and are they on par for this clinical diagnosis? For example, if your patient has CHF and they have edema +2 and their pulses are bound, you're going to say, actually, this is a clinical picture of a person with CHF. Now, how are we going to treat this? So sometimes it's not only the assessment, it's just what lines up with what they're actually here for. And if it's outside of that, or if it's getting worse, you're going to document and you're going to escalate. Now, the GI system, you're watching for function and tolerance. GI status is not only like the abdominal sounds, it's also nutrition. What is their diet plan? Are they NPO? Are they eating by mouth? Are they eating by tube? You're going to say, do they have an NG or OG, or do they have a PEG tube? If they do have an extra tube in place, you're going to look at that site. Is anything to be infusing? You're going to check the bowel sounds to make sure it's actually being absorbed, right? Because if there's no bowel sounds, the bowel is not moving. And is that supposed to be on purpose? Are they coming from surgery and the bowel has been put to sleep and now we have to wake it back up? Or have they just came from home and they're just now distended and constipated? Or do they have an ileus where the bowel is just not moving at all? You need to know that. So when you listen in for bowel sounds, yes, you hear the gargling, right? Everybody has been hungry and you hear your stomach talk. That's what bowel sounds are. You're going to listen to each quadrant of the stomach to listen for that. But you want to make sure that the bowel sounds are present, especially if they're getting fed. If they're getting fed, the bowels need to be moving. With that, you're going to go lower. Have they had a bowel movement? Was it normal, or are they constipated? Do they have any nausea? Is there any nausea or vomiting? When the bowel stops moving, let's say if they have an ileus or a small bowel obstruction, ileus means the bowel mobility is stopped or is slowed down. Small bowel obstruction means that there's something blocking the food to go through the whole GI system and to actually be formed into stool. That stuff is going to back up. So that's where nausea, vomiting starts to happen. So all of these things relate together, but it starts with knowing the key factors of each system. We're going to go to the GU system, or the urinary system. Now, you're going to look for the output and the change. Urinary system, again, all the medication that we give is going to have to be excreted out through the urine or the stool generally. So we are going to look at how much urine are they producing. We like to see at least 30 an hour. If that person is independent, of course, they're not going to pee 30 on an hour. It's going to be in a cluster, but you're going to report the output to say everything that we're giving medicine-wise, it has to come out. So are we receiving out the output equal to what we are giving? Fluids by mouth, medications, tube feeding, we all add these up to see if it's equal to the output, to make sure that I's and O's are equal. Are they holding urine? If they're holding urine, is the bladder distended? You look at that and you'll start to see, is it puffy? Is it tender? If they're retaining, let's say that person hasn't peed for 6 hours, and if they did pee was very few drops of urine, you may have to do a bladder scan. With the bladder scan, it'll show you how much urine is still left in the bladder. If it's over 300 at most facilities, you're going to straight cath them to get that urine out. 2 or more straight caths is going to cause for indwelling Foley, because it seems like that person's not able to empty their bladder independently. All of these factors can actually cause deterioration, holding on to your urine, sudden incontinence, and it can actually dictate that something else is happening underlying. These are all abnormal findings, and it requires follow-up, reporting, and documentation. Lastly, we're going to go through the skin and peripheral. Now, you are looking at the color, the temperature, sensation, pulses, and integrity and perfusion when you look at the skin. But you're also checking for any new openings, skin breakdown, discoloration, non-blanchable redness, cool extremities that starts. Cool extremities show you that temperature changes, yes, but it's also showing you that perfusion is decreasing. So again, you're going to look back at the diagnosis. Is this person here for arterial disease or peripheral venous disease, right? Do I have to elevate their legs, or do I have to put them put the legs down? Or is there something else going on where I might need to warm this patient up? Or is there other factors at play? You're going to check the capillary refill, because that also shows perfusion, right? If it's delayed greater than 3 seconds, there may be a problem. All of these findings are abnormal. It should not be ignored. It should be reported and documented. So the big picture, nursing assessment is not about memorizing normal values. It is about knowing the normal, which we learned in nursing school. And now you're going to say, what does the normal look like for my patient? Based on their medical profile, why they're here, their medical history, what is their normal? What is their baseline? How do I keep this patient stable? And if they become unstable, how will I escalate it, and what treatments need to be put in place for them? You have to recognize this, because then you are able to see the abnormal findings for your patient. When you find something abnormal, you can assess, you report it, and then you document it. This is how nurses protect their patients and their license. So this is why it is so important to not only know lung and heart sounds, it's to know what is the abnormal that you're looking for, and what does that actually mean. When you know what the normal sounds like, the abnormal is automatically going to stand out. And so I'll break those down in separate videos to come. This is a system-by-system framework that I actually go over in the New Nurse Fast Track, so you can know exactly what to watch out for and when it's time to escalate. So if you want my support on the shift, go ahead and click the link in the bio, and I'll see you at the next video. Don't forget to follow me on this channel. I'm always teaching about new nurse education. I don't want new nurses to fall behind. I don't want new nurses to feel like they're alone or not supported. We're in this together. You're going to be the nurse of your dreams, and you're going to be great. Now, the next video, we're going to go over respiratory assessment a little bit deeper. Lung sounds, oxygen trends, and when to escalate. Welcome to Med-Surg, and this is the orientation that every new nurse deserves, but rarely gets. My name is Nurse Key, and I will be your instructor. I have been a nurse for the past 6 years. I am now a registered nurse. I started off as an LPN, and now I'm working my way through nurse practitioner school. So if you're a new nurse and no one has ever explained this to you, this series is made for you. Now, respiratory assessment on a Med-Surg unit. What does it look like? What changes matters? And when should you escalate? Now, respiratory is one of the top declines in a hospital setting, right? Respiratory distress, respiratory failure, and respiratory arrest. Respiratory decline is one of the most common reasons Med-Surg patients deteriorate. And the signs actually show up before it becomes the emergency, but sometimes they can be missed. Now, this is why respiratory assessment on Med-Surg is not optional. It is crucial and essential. This is critical thinking in action. So here's the rule. You must know what normal respiratory status looks like for your patient and just in general. When you assess abnormal findings for the patient, These findings have to be documented and escalated, okay? So when you assess respiratory status, you are looking for 4 things. You're looking for the respiratory rate and pattern. You're looking for the work of breathing. You're looking for oxygen requirements, and you're looking for or listening to the lung sounds. Now, number 1, respiratory rate and pattern. What matters? Now, respiratory rate will be one of the first things that change, and it could be actually the slightest and the most subtle to catch. So you're going to look for, is this rate normal for the patient? Is it trending up? Is it trending down? Is their work of breathing going up, or is it going down? Is their breathing shallow, or is it irregular? Is it becoming loud and they're posturing, or they're maybe a little struggling? Now, let me tell you, usually, again, it's subtle. So they're not going to just become agitated or restless suddenly, but it can happen. So a rising respiratory rate is often an early sign of distress. If it's abnormal, report it and document it. Now, number 2, work of breathing. This is huge. So work of breathing is basically telling you how hard a patient is breathing to actually get air. And a lot of mistakes that nurses do, they'll say, well, the patient say, hey, I can't breathe. And you check pulse ox and you check their respiration rate, right? And you say, well, your O2 is fine. Your respiration is a little bit elevated, but the O2 is fine. No, but if a patient is saying that they cannot breathe, it may be something else going on that you can't see. So you're going to assess for the use of accessory muscles, nasal flaring, tripod positioning, right? Or if a patient says they're short in a breath, go ahead and report it. It's better to be safe than sorry, regardless of what the vitals are telling you. If it looks like a patient is doing hard work to breathe, this is abnormal, even if the O2 sat is okay or within normal limits. Number 3, we're going to look at the oxygen requirements. The trend is not just a number, it's telling you something else of the clinical picture. So oxygen saturation is just one piece, right? What matters more is the oxygen level that they're on and how much support it takes to actually maintain a proper oxygen saturation. If that patient goes from room air to nasal cannula to a high flow, we're having higher and higher demand of their oxygen needs. Something is going on, and this is a trend that has to be reported before it gets out of hand and there is not a proper treatment in place for this person to stabilize. And number 4, we are going to listen to lung sounds and understand what we are listening for. Lung sounds literally sound like the act of breathing, right? The inspiration and expiration that you do on a daily basis, and you hear yourself or other people breathe. This is what you're listening for lung sounds. At full capacity or volume, it's going to be a full, clear lung picture. If it sounds like the volume has turned down and you barely hear it with your stethoscope to the chest, this is diminished. If it feels like water, or it sounds like water or fluid over the lungs and you hear like crackles, this is considered crackles. If it's like a paper rustling, it's rails. It's like a musical sound when that person is breathing. Crackles, most of the time, can be cleared if that patient has a proper gag and cough reflex, right? If it's sputum, sometimes you have to clear your throat yourself and you can feel the tension. Ask them to take a deep breath and cough for you. See, and then reassess the breath sound and see if they have cleared up. This is just one example. All right, so you're going to see, as a new nurse, you're going to ask, is this new? Is this worsening? Is it spreading? Now, when they had clear lung sounds and now they're diminished, that's the problem. If they were diminished on one side, clear on that side, and now they're diminished on both, that's the problem. If you hear no breath sounds where they were clear lung sounds and the stethoscope is actually turned on, make sure you have to turn the bell on most times to hear on some of these models. That is an abnormal reporting, and that needs to be escalated pretty quick, actually, if you hear no breath sounds where there were some. And with active symptoms too in that patient, you're going to have to escalate that pretty quick and document it. Now, again, when respiratory findings require escalation, this is when the respiratory status is worsening. They need more oxygen to even just be stable at a proper oxygen saturation level, which would be greater than 95%. or if the work of breathing is increasing. This is no longer something to just watch quietly and just contemplate and ask your coworkers. Let's go ahead and report this to the charge nurse or the doctor. You don't need to know the treatment. That's so important for new nurses to understand. You do not need to know what treatment should be given. You just need to know to report it. That is the main thing you need to know. When it gets weird, when it gets abnormal, when it gets hectic, report it. Ask the provider to come to the bedside or call rapid response, depending on what your protocol is at your facility. You need to recognize that the level of care that you are giving on your unit may no longer be appropriate for this patient, and they may need a higher level of care for treatment. New nurses sometimes wait because oxygen saturation still looks okay. But respiratory failure does not start in the numbers. It starts with the picture your patient is pictured. It starts with the picture of your patient. When they start to get restless, they start to get agitated, when they start to breathe slower or a little faster, the color changes, they start to get cool. These are all things that are adding to the picture. You don't want to wait until they're fully non-responsive. You don't want to wait till they're fully agitated or when breath sounds fully change. It's slow things that make the difference. The small things add up in nursing and they become big problems if we don't catch it in time. So this is why knowing the normal lung sounds is important, and understanding what your patient's lung sounds they sound like. Anything abnormal is going to stand out immediately, and it's important to reassess. I will break down lung sounds in a different video so you can understand the difference. But this is the exact respiratory assessment framework I break down in the New Nurse Fast Track. New nurses often do not have enough support. We have a roadmap to go through nursing school, right? We apply, we go to clinicals, we go to classes, we do the checkoffs, we know to pass NCLEX, get our job, and then now what? We're told to learn on the job, don't ask too many questions, figure it out, read the book, but you need about 3 books to actually understand these topics, to learn critical thinking, and no one is really there to give us the track to success, right? And so I'm bridging the gap. The New Nurse Fast Track is made for new nurses in their first year to give them the exposure to all the topics and all the situations that you will go through as a new nurse. The link is in the bio, and I will see you for the next video.